Hi everyone, my name is Kate Schneider and I'm coming to you today from the Friedman School of Nutrition Science and Policy at Tufts University. And I'll be sharing my research on household diet quality and the cost of nutritious diets in Malawi. Policymakers around the world are increasingly recognizing that eliminating malnutrition in all its forms cannot be accomplished by the health sector alone and requires deliberate actions to create a nutrition-sensitive food system. A nutrition-sensitive food system is characterized as one where all people have continuous access to safe, diverse, nutrient-dense foods at all times and are empowered, knowledgeable, and economically able to choose them. Food prices and the availability of food items offer underutilized analytical tools for the transformation of food systems towards becoming nutrition-sensitive. They can be used to diagnose how well a food system currently facilitates access to a healthy diet for all, identify policy levers, and monitor and evaluate the outcomes of policy action. Our analysis combines household survey panel data with monthly market food prices, and we match every rural household to the nearest district central market to identify the retail prices that household may face. We use the relatively new Malawian food composition table to identify the nutrient composition of different foods and establish human nutrient requirements as defined by the dietary reference intakes based on reference weights and heights according to the WHO child growth standards and references. We first define household level nutrient requirements based on nutrient density. And to do this, we identify who in the household among the members age 4 and up has the highest nutrient quantity needed per unit of energy. And we do this for each nutrient separately. And then we use that member's nutrient density need to define the density of the household diet for that given nutrient. The total quantity of the household diet is defined by the sum of individual energy requirements, and we add the needs of children 3 and below on top of the household total. This method is flexible to household composition and incorporates the reality that in Malawi, like in many places around the world, families eat together from shared meals, and it results in a diet that is dense enough in every nutrient that if each member has their energy needs satisfied, all of their other nutrient needs will be met. We then estimate adequacy ratios of observed consumption relative to the household nutrient requirements, and use energy-adjusted ratios to separate poor diet quality, meaning diets that are not dense enough or are too dense in certain nutrients for whatever quantity of energy was reportedly consumed, from diets that lack sufficient food quantity. And next, we use linear programming to calculate the lowest cost diet that would be nutritionally adequate for the household, and we define upper and lower bound scenarios to estimate a plausible range of the household cost. The lower bound is characterized by a scenario where each household member eats a tailored, individualized diet that meets only their own nutrient needs. And the upper bound reflects household food sharing using the nutrient density approach I just described. And finally, we identify the shadow prices of individual nutrients from the linear programming solution, which identify the nutrients that are the costliest to obtain. The shadow price reflects the amount the diet cost increases for a 1 unit increase in the nutrient requirement or relaxation of the upper bound limit. Turning to our results, we find that the majority of households are consuming diets insufficiently dense in more than half of all nutrients. More than 95% consume diets inadequate in lipids, riboflavin, vitamin B12, and selenium. Between 60 to 95% consume inadequate protein, vitamin A, vitamin E, niacin, folate, calcium, phosphorus, and zinc. And our analysis of zinc intake is particularly interesting because looking at food consumption, we estimate a lower probability of inadequacy than was found with the recent micronutrient survey that measured biomarkers of zinc status and estimated nearly all Malawians likely have inadequate zinc. However, from our analysis, we can also see extremely high copper intakes, which could explain this discrepancy, since high copper intakes impede zinc absorption, meaning that diets are consuming some zinc, perhaps not still in adequate amounts, but that even the zinc that is being consumed in the diet is not able to be absorbed by the body due to the presence of excess copper. Finally, we find that diets are highly imbalanced in macronutrients. About 84% of households are consuming diets too dense in carbohydrates, with 60% consuming carbohydrate quantities in excess of the upper recommended bound, while at the same time most are failing to consume sufficient protein or fat. Turning to the diet cost results, we find that these adequate diets are likely unaffordable for most rural households. Using our two scenarios to bound the diet cost, we estimate that an adequate diet costs between $1.74 and $2.26 per person per day, and that's in 2011 purchasing power parity dollars. In this chart, you see the range of the diet cost estimates over time, the household sharing represented by the blue line, and the individualized diet, which is consistently lower cost, depicted by the green line. And the underlying bar chart shows the percent of households each month for whom the diet was not feasible given the available foods in the market. The individualized diets are available almost 90% of the time, but the higher nutrient density required when families share food is available much less of the time, only about 60% of all household market funds. Comparing this cost to observed food spending, we find that the adequate diet costs between 1.1 and 1 times annual food spending, and is just about equivalent to total expenditure. And these results appear to be driven by a few key nutrients. Riboflavin is by far the most expensive single nutrient in the food system, with a household diet cost increasing over 300% for a 1% increase in the nutrient requirement. And this translates to an increase of $2.33 per day on average per household for a 1% increase in that household's riboflavin requirement, which is greater than the cost of adding an entire additional family member. Riboflavin is followed by B12 with a nearly 28% increase in the diet cost for a 1% increase in B12 requirements, which translates to about 20 cents per day. On the other hand, allowing 1% more copper into the diet would decrease its cost by 144%, or about 90 cents per day, which suggests that keeping copper intakes under the limit that has been shown to produce symptoms of toxicity is a binding constraint for the linear programming. So the copper upper limits are being reached before all other nutrient needs are satisfied, and so the only options of food items that can meet the remaining needs get limited to only those that do not introduce additional copper. In conclusion, we find that most households are consuming diets insufficiently dense in micronutrients and imbalanced in macronutrients, but that an adequate diet is likely unaffordable to most rural families. Furthermore, we find that not only is the higher nutrient density needed when families share food systematically more expensive, it's not even feasible about 40% of the time. We find that riboflavin and B12 are the costliest nutrients to obtain, suggesting that reducing their cost could improve access to healthy diets, and value chains to target could include powdered milk, eggs, usipa fish, and beef. And in our own future research, we will actually be modeling such policy scenarios informed by the National Multi-Sectoral Nutrition Policy and Strategic Plan to identify the most effective ways to increase the availability and reduce the cost of adequate diets. Thank you very much, and I look forward to our discussion.